All right. So, good morning, and thank you for joining um, us in this gynae pathology session. And we will be talking today about cervical glandular lesions. Uh, the What I will try to do today is to help you recognize the clinical relevance of the uterine cervical glandular lesions. You know me, I always like to discuss pathology in the context of clinical relevance. What is relevant to our patients and to our oncologists? We will discuss the formulation of clinically actionable diagnosis. You heard me say this many times. Our report needs to be guiding the clinician to take clinical actions. So we will pick on the specific words that will help the gynecologist make the next step in their management with their patients. We will classify cervical glandular malignancies, and we will follow the latest version of the WHO classification. We will start by general considerations. We want to talk about anatomy. We will talk about adenocarcinoma in situ, or AIS, and its mimics. We will talk about cervical adenocarcinoma and its classification. At the end, we will save a couple of minutes to talk about staging and what is relevant to staging of these tumors. At the first glance, it sounds like cervical pathology has to be very simple. After all, there are only a very limited number of diagnoses we can make. When you really think about it, in the ovary, for example, the list of diagnoses is so huge. But for cervix, come on, like it has to be one or two or maybe four handful of diagnoses that we make. What is so magical about it? The reality is that cervical pathology is really very challenging and frustrating. And when you think about it, my opinion is that the anatomic landmarks are not clearly defined, and many pathologists don't take the time to understand the anatomy of the cervix. And there is a subjectivity in the diagnostic criteria. It's not really very well defined and not really very well reproducible. And we are really not familiar of how clinicians are going to respond to our diagnosis and what are the clinical implications of diagnosis. And that makes it very challenging for the pathologist. So let us start with some anatomic considerations here. I like this diagram, and I shared it probably with some of you before because it shows the pelvic serosa from the rectum, and how rectum starts here at the level of the superior hemorrhoidal vessels, and the serosa recedes or proceeds obliquely to the inferiorly as we move anterior to the anterior of the rectum. And then the serosa, after that recession, it loops upward and it creates this recto-uterine pouch or posterior pouch behind the vagina. And therefore the serosa posteriorly covers part of the vagina and certainly covers the entire cervix, and then covers the entire fundus. But then anteriorly, it is different because it reflects on the urinary bladder. For us, it leaves the anterior cervix bare with no serosa. So look at this diagram carefully and see how the anterior cervix is different from the posterior cervix. Posterior cervix is covered by serosa, but the anterior cervix is really not covered by serosa. When the surgeon wants to do a hysterectomy, by the time you get this hysterectomy, how many cuts do you think the surgeon needs to make to get this uterus out? So one cut is going to go here, where they will separate the cervix from the septum between the cervix and the bladder. So the knife will go here, cutting the serosa, cutting this soft tissue, and cutting this vagina. Posteriorly, this cut will go here. So it cuts the vagina and very little in terms of serosa. So the surgical margin anteriorly is soft tissue, but posteriorly there is really no surgical margin. There's only vaginal margin that gets the uterus out. We will talk about that. So by the time you receive the uterus, it looks like this. Anteriorly, you can see how the serosa stops very high, but posteriorly, the serosa goes down all the way to the ectocervix. And this is highlighting how the serosa, you are used to this. If I give you a uterus, you should be able to know which side is anterior and which side is posterior just by looking at what we call the serosal reflection. The serosal reflection is high anteriorly, but is very low posteriorly. And all of this anterior surface is going to be the surgical margin, but posteriorly, the surgical margin is limited really to the very, very bottom part. So if you look at the uterus, this uterus is cut sagittally. We don't cut the uterus this way anymore, but this is in the old days when we used to cut the uterus sagittally. I like this picture because it highlights the surgical margins of the uterus. So how many surgical margins do we have for the uterus? Again, the vaginal margin, which is this point here, this is where vagina continues. And then there is the radial or the circumferential margin, which is the bare surface of the cervix. And it is mostly anterior because this is where the area that is not covered by serosa. When you fill the synoptic report, the radial and the cervical, pericervical margin is only relevant if the tumor involves the cervix, right? If you have an endometrial adenocarcinoma, as in this case here, here's the endometrial adenocarcinoma, and it's not involving the cervix, you really don't need to report on the cervical margin in the synoptic report. So when you receive the uterus like this, how do you submit your sections? Your first section, your first block is always this block, which is anterior perpendicular, and it involves it will include the ectocervix and the endocervix. This side of the section is all surgical margin. Your second block is the one on top of it. On the mucosal side here, you will have the upper endocervical canal and the lower uterine segment. And posteriorly, part of that is covered by serosa and part is not covered by serosa. Your third section comes from the posterior side, which is mostly this part. It says ectocervix, endocervix, but part of it could be covered by serosa. Your fourth block will be entirely covered by serosa from the posterior side. So this is how the anterior section should look like under the microscope. You get the ectocervical margin. So there's a tip of vagina here, and then you have the ectocervical epithelium, and here's the transformation zone, and here's the endocervical canal. So this part corresponds to this part in the gross picture. Where is the surgical margin? This is a surgical margin. The tip here is the vaginal surgical margin, but this surface here is also the anterior pericervical surgical margin, and you can see it here that is rugged and it is cauterized. Those of you who signed out with me, you will know that when I put this section under the microscope, this is the first area I look at it just to make sure that the surgical margin is negative, irrespective of what I'm going to find in the cervix itself. This part needs to be carefully examined because it is the surgical margin of the cervix. This is a nice composite. I hope you think it's nice. So this is your cervical section. Here is the endocervical mucosa. And these are the endocervical glands. And here's the stroma of the cervix. Out here, what do we have? We have a cauterized tissue. That is this part. That is the surgical margin. As you move up in the uterus, in the lower uterine segment, you start to see hybrid mucosa here with some glands that look like maybe endocervix or lower uterine segment. But back here, the ragged area, the surgical margin is down here, and you can see that we started serosa somewhere in this section. As you move up in the fundus, of course, you have the endometrium, and you have very solid myometrium, and everything is covered by serosa. I hope when you look at the section, you can tell if the section is from the fundus, if the section is from the lower uterine segment, or if the section is from the endocervical canal. And that is, microscopically, you will see something like this when the endocervical glands start to look a little bit funny, less mucus, and then that's what we call hybrid glands, and then you go into the lower uterine segment and the fundus and the endometrium. Again, here you can see that here's the endocervix, and here's some of hybrid glands, and here's the endometrium. Sometimes you run in this situation where the endocervix suddenly becomes endometrium. How does that happen? And that typically happens in patients who had leaps before. When the patient had a leap, the endometrium creeps inferiorly, and it meets the endocervical canal suddenly. So you see this sudden change from endocervix, mucin producing, to endometrial, suddenly, no transition, as you can see down here. So again, in the lower uterine segment, you start to see these hybrid glands that they don't necessarily look like endometrium, but they don't really look like endocervix because they don't really have much mucin. But the stroma of the cervix, as you can see here, it's not really robust in terms of musculature. If anything, it is not muscular. It is so pink because it's full of elastic fibers, and it is rich in nerve fibers. So I want you to develop this sense. You can look at this stroma and say, yeah, I think this is the stroma of the cervix. Maybe lower uterine segment down here. But this is not myometrium. Why is this important? For staging endometrial cancer, and as you know, endometrial cancer is staged as stage 2 when it involves you read that in the textbook, it tells you if there is cervical involvement, it is stage 2. But no one really tells you what cervical involvement looks like. What is really cervical involvement? If you find endometrial glands set in a stroma that is pink and it doesn't have muscle myometrium, then probably you are in the cervix, irrespective of what kind of glands you will see. When you go up in the uterine fundus, you will see that this is very robust musculature. This is how the myometrium looks like. And here are the famous thick-walled, very muscular blood vessels. This is how you know that you are in the uterine fundus. This is a nice table that can tell you the differences between these different zones, between the cervix, lower uterine segment, and fundus, what the glands look like, what the stroma look like, and whether it has serosa on the surface or not. So now let us talk about AIS, or adenocarcinoma in situ, and what is the differential diagnosis of AIS. Remember, the problem starts right here. When we talk about HPV-associated lesions, when you talk about squamous epithelium, you have a very wide spectrum of changes. You have CIN1, we know what that looks like. CIN2 with mitosis. This is with quelocytic atypia. Here you start to see mitosis going in the upper half. Here you have mitosis filling the entire thickness of the epithelium. And then beyond that, you have invasive squamous cell carcinoma, and we classify it into invasion less than 3 millimeters, which is stage 1A1, or invasion more than 3 millimeters, which is beyond that. Why is this distinction important? Because this is the line that decides whether the patient should have lymphadenectomy or not. You will discuss that when you talk about squamous epithelium. But in glandular pathology, you really don't have this luxury. Anytime you think that there is HPV-associated lesion, you have to call it at least AIS. That's cancer. There is no dysplasia here. And of course, there is no such a thing as glandular atypia, cannot rule this or cannot rule, none of that. There is no atypia here. If it fulfills the criteria, you just call it AIS right there. If it shows invasion, you call it adenocarcinoma right there. So you only have two options, and that makes glandular pathology in the cervix rather really difficult because it is very restrictive. You don't have elbow room to maneuver and to say, cannot rule this and atypical, whatever. No, none of that. It's either AIS or adenocarcinoma or nothing else. So what makes this adenocarcinoma? All right, so what we have here is that these glands they look abnormal. I hope you agree with me. They look more blue. It's not like here. Here you have some cytoplasmic mucin. These guys, they lost some of their cytoplasmic mucin. The nuclei are large, crowded, hence the slide looks blue. But the glands, even though they look abnormal, they maintain the lobular arrangement. I don't know if you can appreciate from this power some mitotic figures. Once you see mitosis, then you have to call it either AIS or adenocarcinoma. And I ask some of you, how many mitoses do you allow in an endocervical gland before you call it cancer? And the answer is 0. We don't allow any mitotic figures. Once an endocervical gland has a mitotic figure, then it has to be called AIS or adenocarcinoma. Let us get higher power here. What is wrong with this gland here? This gland has large nuclei. They are crowded. See here how they are elongated. They are pencilated. They are jumping on each other. There is stratification here. I don't know what these guys are doing. You start to see some apoptotic bodies, but you see mitosis. This is enough for you, should be enough for you to call it adenocarcinoma, at least adenocarcinoma in situ. You look here. They maintain the lobular architecture. So now it is an in situ process. Something about AIS as well, if you notice that typically the dysplastic cells do not, sometimes they don't involve the entire gland. They involve only one side of the gland. The other side is not involved. And even when they involve the entire gland, some of the glands within the lobule are involved while other glands are not. Look at this appearance here. You see some of the glands up here, they have these features, crowding, mitosis, apoptosis, but down here you maintain the lobular architecture and it does not involve the entire circumference. More high power, Sometimes here are the apoptotic bodies. Here is your mitotic figure. Here are the pencilated nuclei. You have everything you want to see. And sometimes you start to see intestinal differentiation. Before I leave this field here, let me ask you this. What do you have to say about the complexion of these nuclei? How do they look like to you? How does the chromatin look like? Is it dark and smudged, or do you see nuclear details and you see chromatin details? I hope you can see that they are smudged and blue. It's almost like ink. They are done by ink. And that is the feature of HPV involvement. So when you have an ECC that looks like this, what's wrong with this ECC? Just from low power, it looks dark, doesn't it? And then you get high power, I start to see some goblet cells. The nuclei are pencilated. They are jumping on each other. I may see some apoptosis, and certainly there are mitosis. Then what am I going to call this? Higher power? Here is higher power. Here is your mitosis. Here are the pencilated nuclei. And the nuclei here are not very dark, but they are a little bit dark. What are you going to call this? I would call this at least AIS. Certainly, I don't know if there is invasion or not. If you like P16, here is P16 that can help you, can hold your hand a little bit. On a biopsy, you will get biopsies that look like this. This is a cervical biopsy. What's wrong with it? Well, it is just too dark. The nuclei, again, here are pencilated, jumping on each other. I can probably see mitotic figures on higher power. Look at this here. There is overlap. There is cribriforming. They involve part of the glands while the rest of the gland is negative. So that it's still lobulated. So that fits the bill for at least AIS. So that's how this biopsy should be called. If you like P16, here is P16. If you like Ki67, you can see increased Ki67 index. That can also help you. So now, after all of what we said, what would you call this one? If this is a leap or biopsy or whatever, what would you call this one? I can see the nuclei, the glands are abnormal. They are dark. I can see some elongation, some dark staining. I probably can see mitosis as well. But I think I lost the lobular architecture. There is no lobular arrangement anymore. So this is not AIS anymore. This has to be just adenocarcinoma. So this would be called endocervical adenocarcinoma. Some of the things that give us some grief when you see stuff like that, what is that? That doesn't look normal because it doesn't have the mucin. It looks a little bit abnormal. Yeah, it looks abnormal because it is syncytial metaplasia. You can see here they are forming a syncytium. Why isn't this AIS? It is not AIS because I don't see mitosis. The nuclei are not dark enough and they are not jumping on each other. If anything, the NC ratio here is very low. Okay, what about this one? What will you call this one? This has to be AIS. No, it isn't. Why? Because the nuclei are not elongated, they are round. I don't see mitosis, and I see a lot of inflammatory cells. So that is what we call papillary metaplasia. What about this one? We have crowding, we have cribriforming. Yeah, you may have cribriforming, but you have neutrophils and you have a little bit of reserve cell hyperplasia. Reserve cells are highlighted by P63, and this is the hallmark of the entity known as microglandular hyperplasia. No mitosis. You notice, no matter how irritating these lesions are to you, if you follow the principle, you look for mitosis. I don't see mitosis, so I'm not going to call it malignant. What about this one here? This is just too busy, isn't it? So many glands, Some of them have irregular shapes and sizes and whatever. What is going on here? I think this is a good example of glandular hyperplasia. Some people call this lobular glandular hyperplasia because you can see they maintain the lobular arrangement. It is hyperplasia, it is not neoplasia, again, because we don't have the dark nuclei elongated, jumping on each other. We don't have the mitosis, we don't have the apoptosis. And there is this lesion that was introduced in the last 10 years, what is called stratified mucin-producing intraepithelial lesion of the cervix. We call it SMILE for short. It is an HPV-associated lesion. You can call it, if you call it HSIL, that's fine. That's fine. It is believed to arise from reserve cells in the transformation zone. The hallmark is that you have mucin-containing intraepithelial lesions that can look like AIS. Microscopically, it looks funny a little bit. It looks weird. If you are not familiar with this entity, chances are you may miss it, which would be unfortunate. And it is associated with what is called invasive SMILE or invasive mucin-producing columnar cells. So what would you call this? If I show you this slide, you have mitotic figure here. It's in the upper third. Would you call this HSIL? If you call this HSIL, you have another mitotic figure here. If you call this HSIL, you are fine. That's fine. It's not a wrong diagnosis because you acknowledge HPV and you acknowledge the risk for invasive cancer. So this would be invasive high-grade. It would be CIN3. If you call it, that's fine. But if you notice, you can't really call it CIN3 because what are you going to do with all of these mucin-producing cells? Here it is. Look at on the left side in this field, you have those mucin-producing cells. But I don't think it is just metaplasia because we have mitosis here. I have to call it something. And if you do P16, it is positive, diffuse, and strong. So this is what is called SMILE lesion, which, as I said, is considered to be the precursor of an invasive SMILE carcinoma. I did not make a diagnosis of invasive SMILE carcinoma yet, but I'm sure it exists. What will happen if you leave this patient for a few more months or few more years? They may develop invasive SMILE. They may develop invasive adenosquamous carcinoma. I don't know. So here's another SMILE case here. You can see these. You have to call this something abnormal, but they have mucin. They look like HSIL with mucin. And if you do P16, you can see even the glandular component of the gland here. The glandular part is positive for P16. All right. Moving from AIS now to cervical adenocarcinoma. And I remind you that for endocervical adenocarcinoma, typically they will perform the radical hysterectomy surgery. This is what you receive, and we call radical hysterectomy. When do they do radical hysterectomy? They do it for cervical cancer that is all the way up to stage 1A2 or even 1B1. After this, if in a stage 1B2 or higher, they really typically don't do radical hysterectomy anymore. They usually send the patient to chemoradiation first and then may consider her for radical hysterectomy later. They do radical hysterectomy also if the endometrial cancer involves the cervix, i.e. in stage 2 endometrial cancer. Okay, let me think about this for a second. So maybe what I'm trying to tell you is that radical hysterectomy is a surgery that is performed whenever the cervix is involved by cancer, whether the cancer is primary cervical or endometrial and involving the cervix. they still give the patient a radical hysterectomy procedure. What do we receive in pathology? What makes a hysterectomy a radical hysterectomy? It will have the uterus, it will have the cervix, but it will have to have the parametrial tissue, this tissue here. This parametrial tissue is what holds the uterus into the pelvic wall. So instead of cutting here, as I was telling you before about the hysterectomy specimen, the surgeon has to cut here, i.e. to separate the parametrial tissue from the pelvic bones. Not every gynecologist can do this. So I want to emphasize that only gynecologic oncologists are trained to perform the radical hysterectomy surgery. And where do we find gynecologic oncologists? This is after they finish gynecology residency and they do a fellowship. Most of the fellowships are 3 years. And we find those guys mostly in university setting. Some of other hospitals, community hospitals here in the Twin Cities, they have gynecologic oncologists operating. The point I want to make is that this is not the surgery that you will see if you practice in a smaller setting in a community where no gynecologic oncologists operate. Also, in a radical hysterectomy, you have to have at least 2 or 3 centimeters of vagina excised in the specimen. So what makes a hysterectomy a radical hysterectomy? It has parametrial tissue and it has the upper vagina. You notice I didn't comment about the ovary and fallopian tubes. That is irrelevant. Whether we have the fallopian tubes and ovaries in the specimen or not, that has nothing to do with making the specimen a radical hysterectomy. What makes the uterus a radical hysterectomy? The presence of parametrial tissue and the upper portion of the vagina. What do we do when we receive this specimen? We ink the parametrial tissue and we serially section it, and we submit this separately, and we submit the left side separately. So you get 1 or 2 cassettes, call them right parametrium, and 1 or 2 cassettes and call them left parametrium. As for the vaginal cuff, we shave the margin of the radical cuff and submit that separately in maybe 2 or 3 cassettes. When you receive a simple hysterectomy without parametrial tissue, sometimes you may like just to shave off this margin and shave off this margin and submit them separately, but you will not have any of that. That is only this bulk of parametrial tissue you only get when the specimen is labeled as radical hysterectomy. So here are some gross examples of cervical cancers. You can see cervical cancer here is ulcerated. Here is a mass. But what is common in these 2 specimens is that they come with the vaginal cuff. You see, this much vagina is included, this much vagina is included, and this much vagina is included. So you can tell that these are radical hysterectomy specimens. And here is a big fungating mass of the cervix, of the endocervix. This is another example of advanced endocervical adenocarcinoma. And then you serially section this specimen, and you can look at it in this way. You see, here's the vagina, 2 or 3 centimeters of vagina, and here's the ectocervix. And you see the endocervical canal is replaced by this necrotic fungating mass. So the classification of endocervical adenocarcinoma, as you see it in the CAP checklist, adenocarcinoma NOS or adenocarcinoma HPV associated or HPV independent. The gastric type, the clear cell, the mesonephric, the serous carcinoma, and all that stuff. All of these entities are HPV independent. Of course, the most common one we encounter is the HPV-dependent adenocarcinoma. This came from this paper that was published in 2018, which is the landmark paper classifying endocervical adenocarcinoma into HPV-associated and HPV-independent. HPV-associated, you have these options: the usual type, glandular type, mucinous, mucinous intestinal, mucinous signet ring, and the invasive smile. All of these lesions are known to be associated with HPV. Some adenocarcinomas are not HPV associated, and these are typically more aggressive than the HPV associated. And that is why you can't wishy-washy in your report. In your report, you have to be very clear. And as you fill the synoptic, the CAP checklist, you can see you have to be very clear. Is it HPV associated or HPV independent? Because gynecologic oncologists know that these are typically aggressive tumors and they need to be handled differently. So here's an example of an adenocarcinoma, the conventional, the usual type, the HPV associated. Again, you can see that these glands are abnormal for all the reasons we mentioned before, but I can't call this AIS anymore because they almost lost their lobular arrangement, didn't they? Like, where are the lobules here? Yeah, you can see some destructive stromal invasion, but you don't have to see that to call it invasive adenocarcinoma. Just losing the lobular arrangement will make it invasive adenocarcinoma. Here, this is not a nodular pattern. You can still see some nodular arrangement, but this is just way too much to be just an AIS. So here's another pattern that we encounter in endocervical adenocarcinoma. So adenocarcinomas, the HPV associated, they have atypical mitotic figures and apoptotic bodies, appreciated even on scanning power. You have your elongated pencil-like nuclei that is only in the low grade. Once the tumor gets into grade 2 and 3, you can actually lose that, and I will show you some examples. And you still have some appreciable intracytoplasmic mucin. And you will see associated AIS on the side, or maybe even H-cell lesions, but you can see how the tumor lost its lobular arrangement, and you have glandular confluence like cribriforming with irregular shapes and even some individual cells invading into the stroma. So let us look at some of these examples. This is very low power. What would you call this lesion on the upper left panel? Abnormal glands, yes, they lost their lobular arrangement. And I think even from this power, you can call it adenocarcinoma. The problem with endocervical adenocarcinoma, as you will start talking about in staging and measuring the depth of invasion, we talked about the 3 millimeter cutoff. Less than 3 millimeters may not do lymph node. After 3 millimeters, the patient will get radical hysterectomy with lymphadenectomy. How do I measure the depth of invasion if I don't know where the tumor starts from? And you hear people talk about that, like how do you measure the depth of invasion? Do I measure from here, like here's a normal gland? Do I assume that the tumor started at this level and measure, or what do I do? It's very confusing. I personally don't think it is confusing at all. Why? Because we know that the gynecologist is looking for the 3 millimeter. So this lesion is grossly more than 3 millimeters. So it doesn't matter if you start measuring from here or from here. This is going to be like 1 centimeter. So we don't need to fight about measuring from here or measuring from there. If the lesion is very tiny and it is less than 3 millimeters, it's going to be like 1 millimeter or so. Then again, like a lesion like this. If it is 2 millimeters, then again, whether you measure from here or measure from here, it doesn't matter. It's a tiny lesion, less than 3 millimeters, and probably the patient is not going to get lymphadenectomy. So here's the lobular arrangement, here's the diffuse arrangement, and here's individual destructive stromal invasion with individual glands destroying the stroma. You like high power? Here is high power. What do you see here? I see very abnormal. Everybody will agree that this is an adenocarcinoma. You have your mitosis, you have your apoptosis. The nuclei are even maybe grade 2 or 3 here. They are not pencilated anymore. This is definitely not pencilated. This is grade 3 endocervical adenocarcinoma, very high nuclear grade. You have confluent growth with cribriforming, forming, and this will be easily diagnosed as adenocarcinoma HPV associated. You need to familiarize yourself with this classification. Again, it's in the CAP checklist. The different patterns, pattern A, B, and C. Pattern A is where you still see the nodular arrangement. And the importance of that is that typically adenocarcinoma of pattern A will have no LVI and the patient will not have lymph node metastasis, and these patients don't recur. In other words, you can diagnose this in a leap. If you call an adenocarcinoma in a leap pattern A, most likely this patient is not going to go for a radical hysterectomy with lymphadenectomy, maybe simple hysterectomy. If you call it pattern B, where you have localized destructive stromal invasion, that they still have some positive LVI, and maybe some of them will get lymph node metastasis. Again, on a leap, that may guide the oncologist to maybe be more aggressive. So the pattern, as defined in your report on a leap, will tell the gynecologist where to go for the next step. Radical hysterectomy with lymphadenectomy versus simple hysterectomy with no lymphadenectomy. Pattern C is when you have destructive diffuse infiltration, and those usually have LVI, and those big portion of those will have lymph node metastasis, and they will recur. So that is the patient who gets the radical hysterectomy. So this information in your report on a leap will guide the gynecologist for the right surgery. And here is a leap. What would you call this? Well, let me see. I have HSIL here, so I know I am dealing with an HPV-associated lesion. I think this is an adenocarcinoma. This is past AIS stage, and it is lobulated. So I will call this adenocarcinoma pattern A. And this patient probably will not get a radical hysterectomy. I want you to also familiarize yourself with this paper where they did even more digging into interpreting the biopsy, and they noticed that there are features in the biopsy, not the lead. Here I was talking about the lead. Here I'm talking about even a biopsy. Look for nuclear debris and look for nuclear grade. That's interesting. Look at this. So they found that when you have, look at this case here, this is probably an adenocarcinoma. Why do we have nuclear debris in the lumen? Look at this nuclear debris. Yeah, this is an AIS, or this is an adenocarcinoma, but it has nuclear debris. This is definitely an adenocarcinoma with nuclear debris. So when you see nuclear debris, you may want to include that in your report. You may also want to say something about the nuclear grade. So these are the pencil-like, these are the pencilated nuclei of grade 1, but this is higher than grade 1. We saw a case like that a few slides back. That's grade 2, and this certainly is grade 3. So they found out that with higher nuclear grade and with nuclear debris, these patients most likely will have LVI and will have lymph node metastasis, and they will recur. So there are features that you can list in your biopsy or your ECC, or you can list in your cone or leap the pattern of invasion that will guide the gynecologist on the next step and the likelihood that this patient may have lymph node and they may have recurrence, and they will guide the surgery for them. Here is an example of I think we all agree this is an adenocarcinoma, but it is very mucinous, isn't it? That's a mucinous adenocarcinoma. Yeah, well, we have mucin here, intracytoplasmic, lakes of mucin. You like P16, and here is CK7 and CK20. I'm looking for intestinal differentiation or whatever. It's a mucinous carcinoma. So where does that leave me? It leaves me here. If I had CK20 positivity, I would probably said intestinal type. I did not really see signet ring. I saw some mucin, but not signet ring. So this is how we make our way through this classification. If you call this mucinous carcinoma, I think that's the proper diagnosis. You call this mucinous carcinoma NOS. But fundamentally speaking, this is an HPV-associated carcinoma, which is very different from this case. This is another case that is also mucin producing. It's a mucinous carcinoma. Nobody disagree with that. Yeah, it's mucinous carcinoma, but it is different. Why is it different? Well, for one thing, look how aggressive it is. So these tumors, typically, by the time we diagnose them, they are already very deeply invading into the cervix. What is so different about this case? I don't know what's different. I think the NC ratio is low. Like, it's almost like we have so much cytoplasm here. It is pink. And we always have luminal secretion. Luminal secretion, that is new. So these cases, that cytoplasm is pink. Look how pink the gland is. And they have luminal secretion here. And the nuclei usually are very high grade. And that is called gastric type adenocarcinoma. The cells they have abundant clear cytoplasm or foamy cytoplasm. They have low NC ratio. The glands themselves are irregular, and the nuclei are basally oriented. They may have some intestinal differentiation. As a matter of fact, some people require that you have to see some goblet cells, some intestinal differentiation, even though we call it, I don't want to confuse you here, because I'm calling this intestinal differentiation, but I'm still calling this HPV independent. I hope I don't lose you here. Don't take intestinal differentiation as if I'm saying it is mucinous intestinal type. No, I'm saying there is a little bit of mucinous intestinal differentiation in an otherwise what looks like gastric carcinoma. You will have goblet cells, or you may even have neuroendocrine cells. And this is important because these patients, these tumors are very aggressive. And we believe that what we see as gastric type adenocarcinoma is the end result of an entity that was called minimum deviation adenocarcinoma. Minimum deviation adenocarcinoma is an adenocarcinoma where the nuclei are not really atypical at all, and that is why it is very deceptive. So how am I going to diagnose minimum deviation adenocarcinoma? You diagnose it when you have too many glands, it is too crowded, and the glands look how they look all different. Some of them are elongated, some are branching, some are angulated. They look very different from one another. We believe that this is the kind of like the in situ or the early form of what later becomes gastric type adenocarcinoma. Serous carcinoma is another HPV-independent adenocarcinoma of the endocervix. It looks like just like any serous carcinoma. High nuclear grade, prominent inclusion-like nucleoli, and if you do P53, it is P53 abnormal. According to the criteria of this paper, you cannot call something serous carcinoma of the endocervix unless the uterus itself is negative for serous carcinoma. That is why when we see it on a biopsy, we just call it serous carcinoma, period. We don't say endocervical or endometrial, because chances are it is endometrial that is stage 2 invading the cervix. But when you get the cervix out and you see that the endometrium is completely negative, now you can call it primary endocervical HPV independent serous carcinoma of the cervix. Few words about the entity called adenoid cystic carcinoma of the endocervix. The importance of this entity that it has poor prognosis. The gynecologic oncologists don't like it. Then it's just like any adenoid cystic adenocarcinoma with basaloid cells, cribriforming or tubule forming, and then you have these cystic areas that have mucin or eosinophilic material in them. If I show you this slide, you will call it adenoid cystic anywhere, in the lung, in the salivary gland, in the cervix, anywhere. It's an adenoid cystic carcinoma, which is slightly different from the adenoid basal carcinoma. It may look similar, but from low power, it looks very, very basaloid. It's almost like a basal cell carcinoma. The interesting thing about this entity, adenoid basal carcinoma, it is very rare. It is HPV associated, but it has an excellent prognosis. So excellent to the point that some gynecologic pathologists don't even like to consider it as cancer. It never metastasizes. Those patients typically are older patients, postmenopausal. It is diagnosed as an incidental finding. You are looking at a hysterectomy, and then you find an area that looks like this. It is adenoid basal. The significance of this is that you make sure that your gynecologist knows that you are not calling it adenoid cystic. You are not calling it that, because this is a bad actor, but this is a very low malignant potential tumor. A word about mixed Müllerian tumors. You saw this. I presented this table many times. And you will get carcinosarcomas and adenosarcomas of the cervix. In the cervix, the entity that is more likely to be encountered is the adenosarcoma, where the glands are kind of like benign. They just basically, they have some ciliated metaplasia, but the stroma is very busy, and then you start to see mitosis in the stroma. From low power, you see this phenomenon of coughing, where the stroma is condensed about abnormal, like phylloides kind of glandular arrangement. So this is the phylloides counterpart of the cervix. I want to say a word about staging. As I said, I just want to highlight to you that the 3 millimeter depth of invasion is the cutoff, and it is important. That is the difference between the different stages, and this is how they plan their surgery. As I said, beyond that, the patient gets a radical hysterectomy with lymphadenectomy. Less than 3 millimeters is going to have less aggressive surgery. And I want to spend 2 more seconds here just to remind you that we don't use words like superficially invasive or microinvasive, none of that. Please don't use these words, because they don't mean anything. When you say a carcinoma is superficially invasive, what does that mean? Is it more than 3 millimeter? Is it less than 3 millimeter? That's what your gynecologist wants to hear. So they remove these words completely from the pathology of the female genital tract. No more microinvasive, no more superficially invasive carcinoma. You call it invasive carcinoma, and you measure the depth of invasion. So at the end, I hope I was able to highlight to you that meaningful interpretation of cervical pathology needs solid understanding of its anatomy. Go over the anatomy. It is deceptively simple. When you look at the slide, make sure you understand where is the cautery, what was a margin, what is not a margin, where vagina ends and the cervix begins. Subtyping of endocervical adenocarcinoma based on the role of HPV is very, very important. And it needs to be clearly articulated in your report. You can't call something endocervical adenocarcinoma and move on. No, you have to call it HPV associated or HPV independent. There are rare subtypes of cervical cancer, and you just need to familiarize yourself with them because they have significant clinical implications. And if it doesn't look right to you, just show it around, show it to someone who has seen more cervical pathology. And as I always say, clear and open communication with your gynecologist is critical to avoid any ambiguity. Any ambiguity in our report will backfire because they are not helpful for the gynecologist, and they certainly are not helpful for our patients. You think you can hide information in your report and move on, nobody will notice, it will backfire. You can't call something just adenocarcinoma and move on, or atypical, cannot rule out whatever and move on. Call the gynecologist and ask them, what did you see when you did the colposcopy? Did you see an ulcer? Did you see a mass? Was it a polyp? What was going on? Was there acetocyte areas? Is there HPV history? Talk to your gynecologist to clarify the history of endocervical lesions. Thank you guys so much. I will stop here. Please send me emails if you have questions, or come to my office and talk to me about this. Thank you.
Thank you so much, Dr. Khalifa. I really appreciate it.
Thank you, Dina.